Um, as I was introduced, I am a clinician and a researcher at Mass General Hospital, and I would like to thank the organizers for inviting me today to tell you more about updates in mitochondrial medicine and mitochondrial diseases. And so these are my disclosures and disclaimers. I wanted to start by saying how challenging it is to be working with mitochondrial diseases. This is from the mission statement of the North American Mitochondrial Disease Consortium, which states that the clinical spectrum of mitochondrial diseases are extraordinary. All too often leading practitioners to either underdiagnose mitochondrial diseases, what's this complex disorder that we are dealing with, or overdiagnosing patients. So this disorder is so complex, it has to be mitochondrial. So it's really incumbent on us, the metabolic and geneticist and mito experts, to try to have a better sense of how well we can serve our patients and better diagnose them. And to that effect, I would like to tell you a little bit more about what's new biologically that we understand about mitochondria and mitochondrial disease. In recent years, there has been a tremendous effort to try to get a better sense and differentiate between primary mitochondrial disorders that are genetically inherited and secondary mitochondrial dysfunction that can be easily found in many common disorders. We all know that ATP is the energy molecule that animates life, and we all know that energy production dysfunction is at the heart of several different common disorders. So environmental factors, somatic mitochondrial variations, and other epigenomic effects can cause OXPHOS dysregulation and decrease ATP production that is now commonly accepted as a pathophysiological pathway in metabolic and neuropsychological disorders. But what we have discovered in recent years is that ATP also acts as a signaling molecule that is crucial in the innate immunity, inflammation control, and metabolic memory function. And that opens the door to so many more common and complex disorders that we deal with in clinic. And some of them are listed here. And as you can see, autoimmunity, chronic fatigue syndrome, autism, complex neuropsychological disorders, all these can present with complex phenotypes and can mimic mitochondrial disease. And when we see these patients in our clinic, we really have to be diligent to try to categorize which one might have a primary disease from which one has a secondary dysfunction. And this is very important because in the US right now, there are about 40% of children born with 60% and 60% of living adults who have these disorders. And so there's a huge amount of patients seeking medical advice right now that may have a secondary dysfunction and not a genetically inherited disease. To this effect, we have published this paper, Diagnosis of Possible Mitochondrial Disease and Existential Crisis, which I urge you to read, that lays out the potential harm of not doing this due diligence by ending the diagnostic odyssey prematurely for our patient, missing potentially treatable disorders, and incurring psychological burden on the patient if they are given an erroneous diagnosis of mitochondrial disease. So phenotypically, what is also changing is that we recognize now that mitochondrial diseases represent a very heterogeneous spectrum. We have hundreds of different diseases. We have hundreds of different genes that underpin these disorders. There are different symptoms at onset, even for the same syndrome or the same disease. There are different symptoms between syndromes and diseases, and the progression can be very variable even within the same family. So how do we recognize these, and how do we facilitate differentiation between these disorders? Historically, we have had these canonical syndromes that were described that are all referred to by these acronyms: MELAS, MERF, LEBERS, NARP, KSS-PEO. And these historically have focused on the most severe of the phenotypes. And yet what we found now is that even when patients are found to carry a mutation that can cause these symptoms but don't have the full spectrum of the disease, they are still being given these acronym or these designation. And that has become problematic in the era of clinical trial, where we are trying to select for very specific phenotypes to enroll in trial and in research so we can better understand the disease and come up with that cure. So it has become very important, and the mission of the Mitochondrial Medicine Society and other consortia for research to identify patient appropriately. So we only give these acronyms to patients who have the full spectrum of the disease. For example, someone who has the 3243 mutation, who may not have stroke-like episode or strokes, may not be given the MELAS designation, but rather mitochondrial disease that is multisystemic or specific to an organ that is caused by the 3243 mutation. And that is going to be very helpful to be able to enroll these patients in further study and better understand the disease spectrum. Such an effort is being led by Dr. Patrick Chinnery in Cambridge, UK, who has recently developed this MitoFin database that is freely available at this address. So what he has done is really curate all the publication pertaining to mitochondrial disorders, and has curated more than 70,000 such publication, and used human phenotype ontology terms of about 27,000 terms to create this database. So when you log in, I chose here to represent the mitochondrial DNA a mutation that he investigated. You have all the pathogenic mutation that are known, all the publication that pertain to them, and the number of publication for each, and then the HPO phenotypical expression for each of these by mutation type. And so hopefully this is going to enable hypothesis-free definition of mitochondrial DNA clinical syndromes with an overview of the relationship between heteroplasmy and phenotype, and identification of under-recognized phenotypes that are caused by these mutations. So this is in an effort to try to better characterize these very complex phenotypes sometimes. Which brings us to what's new molecularly. So it's nice to recognize these syndromes and these diseases clinically, but we still have to confer them molecularly. So how do we do that? The complex mitochondrial disease are known because of their bigenomic input. There is the mitochondrial DNA and the nuclear DNA, and they lead to different types of diseases with different inheritance and different prevalence of the disease. We still don't have very accurate international prevalences, and we still rely on the Newcastle representation of about 1 in 4,300 people affected by mitochondrial disease. But what we have seen over the years is that the methods of disease and gene discovery has changed over time. So this graph represents the changes between the first diagnosed or the first described Leber hereditary optic neuropathy mutation in 1988 by Dr. Wallace to 2020, where we have seen the advent of next generation sequencing and high scale genomic testing. And so we shifted from mitochondrial DNA sequencing and targeted nuclear gene analysis to more targeted next generation panel whole exome sequencing, and more recently whole genome sequencing, which led to an exponential discovery of new genetic underpinnings and causes of mitochondrial disorders. This shows you the yield of, or the diagnostic rate of, these mitochondrial disorders. So even in 2021, with the most sophisticated technology we have, the yield remains suboptimal, ranging from 7% to 70%, depending on the cohort that is studied, with yield being higher in pediatric cases that remain more well-defined and more well-curated compared to other disorders that are of adult onset maybe, and who may have a more complex presentation that can mimic or phenocopy mitochondrial disease. So these patients might be enrolled but don't end up having a mitochondrial disease. So because of this exponential growth in molecular technology, we are now at about 350 genes that are primarily linked to oxidative phosphorylation machinery and biogenesis, and another about 1,500 various genes that are secondarily impacting mitochondrial function, the oxidative phosphorylation machinery, and other cellular function. And despite all of these genes that we know of, of, we still have very large cohorts of undiagnosed, clinically suspected mitochondrial disease patients. So there are definitely more genes to be discovered and more genes to be studied. One resource that could be helpful to the geneticists in the group or to people who order genetic testing in general is this Mitochondrial Disease Sequence Data Resource Consortium. This is led by Dr. Marnie Falk at Children's Hospital of Philadelphia. This is a global international effort to try to collect and share molecular and phenotypic data of patients with mitochondrial disease. So if you have a report back with a variant of unknown significance, or that you have a new gene, you can go to this resource and you can look up whether it has been reported before and with what phenotypical description. You can easily request access from the MSeqDR team and you will get an account formed. Another effort led by Dr. Shamima Rahman in London is this Lee map. She created this to enhance the interpretation of whole exome sequencing data and to aid clinicians in providing faster and more accurate diagnostic for patients and the appropriate measures that can be taken for optimal management. Again, this is freely available at this address. You can log in and input any of the Lee syndrome genes that you are working with, and it'll give you a wealth of information about the location of the gene within the mitochondria, the biochemical effect, the phenotypic expected expression, even MRI imaging, and what the progression and the treatment should look like. So this is really a great support for those clinicians who are dealing with very rare or ultra rare genes that cause Lee syndrome. And so this leads to what's new diagnostically. Obviously, with the advent of these next generation sequencing technology, molecular testing for the diagnosis of mitochondrial disease has become the gold standard for the diagnosis. Of course, I understand this might not be readily available for everyone worldwide. And so if you are suspecting a canonical syndrome, you can still do screening for point mutation, mitochondrial DNA sequencing, deletion and duplication analysis. But if you have access to large-scale testing, that would be the first tier recommendation to start with whole exome sequencing with mitochondrial DNA sequencing as well. In 2021, we have the luxury of having several tissues that are available that we can test for. Of course, blood remains the more convenient medium to use because of ease of access. But for mitochondrial DNA disorders that have notoriously low heteroplasmy in blood, urine or buccal swabs are the best options to replace blood so that you could find that heteroplasmy level at higher level that can be detected by these technologies. So with all these molecular technologies available, is there still room to the classic biochemical and functional assay to diagnose mitochondrial disease? Well, I would say we haven't been using that as the first step to diagnose patients just because genetic testing has been so widely available, but there still remains room for the use of these. The current limitation for these tests, however, remains the imperfect sensitivity and sensitivity, the secondary mitochondrial dysfunction that can lead to erroneous diagnosis of mitochondrial disease, and the variability in method reference ranges and interpretation of these studies. So one thing that I would caution people in terms of pathological reports includes the classification of an abnormal muscle biopsy if there is reference to ragged red fibers. These ragged red fibers, COX negative and SDH positive fibers, have to reach a specific percentage of abnormality to be able to be considered as abnormal, because these can be present in the normal physiological aging process. So a certain percentage of abnormal fibers needs to be present per age group to confer pathogenicity. Same thing goes for respiratory chain complex functional assays. They have to reach a certain abnormality level compared to reference range for them to be considered as pathogenic. So for example, a 50% decrease would not reach that threshold of pathogenicity and can just be a measure of a secondary mitochondrial dysfunction or a processing problem or a tissue quality issue. And I have to caution also about mushrooming commercial labs offering respiratory chain complex enzyme testing on buccal swabs and other medium that are not well accepted in the community. So this remains to be done really on well-studied tissues such as muscle. Also, a word of caution about using functional neurological testing, just to know that nerve conduction studies, electromyography, and CK levels might be normal, even in patients who have a confirmed mitochondrial myopathy, and so having a negative or a normal test does not exclude the diagnosis. This brings us to biomarkers. Everyone's talking about biomarkers. Unfortunately, we're not there yet in mitochondrial medicine to have a very robust biomarker that we can use clinically to diagnose patients. In 2016, there has been a lot of interest and enthusiasm about GDF15 and FGF21. Both biomarkers have been reported to be specific for mitochondrial disorders. GDF15 remains the only clinically available biomarker to test, at least in the US, and even with its with all the reports pertaining to specificity to mitochondrial myopathy, not mitochondrial disease, that's a distinction that needs to be made. GDF15 is supposed to be elevated in mitochondrial myopathy only, and not in general in mitochondrial disorder. The variation in the GDF15 amongst patients with myopathy is so large that it overlaps with non-mitochondrial myopathy patients and even healthy control patients. The other confounding factor is that GDF15 can be elevated in many other common disorders such as inflammation, obesity, heart disease, and even diabetes. And so having an abnormal GDF really needs to be interpreted within the specific context of the patient, and a positive marker is not always reflective of a primary mitochondrial disease diagnosis. Finally, imaging technique still have a role when you find very pathognomonic lesions, such as these represented here. There have been many efforts to try to come up with a genetic diagnosis just by looking at MRI imaging, especially for Lee syndrome patients. Those efforts have not panned out yet. We cannot still molecularly diagnose patients just by looking at their MRI, but we are getting there with artificial intelligence and having larger cohort of patients to study. So now, what's new therapeutically? We are better at clinically identifying patient. We are better at confirming diagnosis molecularly. We are better at surveying what's wrong with patients, but can we treat them? And unfortunately, in this area, we're still lacking. We still don't have that cure that everyone is really hoping for. And treatment and therapy remains symptomatic. Surveying every organ that might be damaged and really taking care organ by organ for the patient with different subspecialists, and also supporting the system overall, because mitochondrial disease burdens the whole body, not just specific organs. Of course, avoiding environmental toxins such as alcohol and smoking is very important, especially in patients with Leber's hereditary optic neuropathy, where we know these can precipitate the disease. And so how do we manage overall disease burden relief? We try to minimize energy losses and optimize energy gains. And the way we do that is still by subscribing supplements, which we call the Mito cocktail in the US. It's not an alcoholic beverage, but it's a mixture of multiple supplements that have been used over the years to try to stimulate the functioning of mitochondrial enzyme, reduce oxidative stress as an alternate source of energy, and so forth and so on. These have been anecdotally used over the years, but there's still in 2021 a lack of robust evidence-based trials to support their use, except for a few of them. And that's why in 2015, the Mitochondrial Medicine Society has come up with this consensus statement recommending only the use of coenzyme Q10 in the form of ubiquinol, alpha-lipoic acid, and riboflavin. These three have been shown in small clinical trials to improve muscle strength and decrease and increase energy. Creatine has been used on and off with these, and so that can also be used depending on the patient renal function. Folinic acid should be used for those who have central folate deficiency, and then L-carnitine should only be used if there is a documented deficiency of L-carnitine. Of course, when we start, it's better to use these supplements one by one. Our studies have shown that it takes about 3 weeks to 4 months for patients to see subjective benefits. And so they have to really wait a long time before they decide whether these are working or not. I have to say, in the US, these remain largely uncovered by insurance, so patients have to buy them over the counter, and they tend to be very expensive. I put this here for your reference. These pertain to specific mitochondrial disorders that have a specific supplement recommendation. For example, biotin thiamine responsive basal ganglia disease, which does well on biotin and thiamine, same for riboflavin transporter defect, and so forth and so on. I just wanted to point out the ketogenic diet, which is recommended for patients with pyruvate dehydrogenase deficiency. We are always asked by patient whether there is a specific diet that they have to follow because of their mitochondrial disease. To this date, there isn't one that has been studied and that is well accepted. I would caution people not to use ketogenic diet for mitochondrial disease in general. It can be detrimental. It has been used as a modified Atkins diet in a subgroup of patients with mitochondrial myopathy, and over a few weeks it has caused elevated CK level and worsening of the muscular symptoms. And so it does not work all across the board and really has to be dedicated to pyruvate dehydrogenase deficiency. Stroke-like episodes and strokes for MELAS have special recommendation to use nitric oxide donors as a vasodilator treatment with arginine or L-citrulline. More recently, taurine has also been used. These are not internationally accepted recommendation, but remain the mainstay of therapy in the United States, where most of our patients with MELAS, when they get admitted with an acute stroke, they get IV arginine and are maintained on oral arginine between acute episodes. Sorry. One of the very important recommendations that we give our patient is really to exercise, because endurance exercise and resistance training at least 3 times a week has been shown to improve biogenesis, energy production, and overall well-being. So this is a study that was done back in 2005 with polygamma mice. These are littermates. They are housed in the same environment, have eaten the same chow, and have drank the same water. The only difference between them is that these two that look very well, they are very active and have a very shiny black coat, have been exercised since they were able to for 40 minutes 3 times a week, as opposed to their brothers who look very, very sick and very, very different. So just by changing exercise in this mouse cage, you could see the difference that exercise can do. So we do recommend all our patients exercise. One thing that is new that I wanted to bring your attention to is the publication of this updated safety of drug use in patients with primary mitochondrial disease that supersedes all the tables that have contraindication to use medication for patients with mitochondrial disease. This was an internationally led effort that was very, very specific in reviewing all the in vitro, in vivo, and in human trial data for all of these medication to really try to come up with evidence-based recommendation. And the evidence shows that these are safe to be used in patients with primary mitochondrial disease, despite all that has been published and said before. And this includes metformin and statins and anesthetic. In the under supervision from a physician, it's the benefit of using these in patients when they need them outweighs the minimal risk of mitochondrial toxicity. The only specific point of attention that we address in this publication is not to use valproic acid for patients who have full gamma mutation, and also to use neuromuscular blockade cautiously in patients who have a mitochondrial myopathy. So this is publicly available on our website, and this has also been disseminated to all the advocacy group and has been translated in several languages for patients to have access to. Finally, in terms of mitochondrial treatment, this is mitochondrial replacement or donation therapy. It is meant to help women with mitochondrial DNA mutation have children that are immune of these mutation by using donation from a woman without mitochondrial DNA and moving the nucleus of the mother with the mitochondrial DNA into that donor egg and fertilizing it with the sperm of the biological father, either in the metaphase to spindle transfer stage or the pronuclear stage of embryonic division. The children born to these methodology would have both nuclear DNA from the biological parents and the mitochondrial DNA from the donor woman. There is actually now a clinical trial in the UK that is going to look at the first 75 kids that are born through these technologies, and it's being done under very specific ethical scrutiny. Unfortunately, because IVF regulations are not well established worldwide, there remains the use of this without ethical approval, and there were babies that were born in different places in the world with this technology. So we still have to wait to see what the long-term longitudinal data shows in terms of safety and non-revert and mitochondrial DNA genotype not reverting back to the mutative state that is maternally inherited. Okay, so now I would like to finish by giving you an update on the research and development in the mitochondrial medicine field. As you can see here, these are the number of publications over the last 30 years. And you can see here mitochondrial scientific publications have exceeded any other organelle in the body. And that has led to a lot of interest from industry to pursue clinical trials and research to try to cure mitochondrial disease. There are several therapies that are under investigation right now, including PGC1 alpha modulators, NAD modulators, gene therapy, cardiolipin stabilizers, nucleoside therapy, antioxidant therapy. And there have been so many different trials that have gone through and are still ongoing over the years, over the last 11 years per se. These are some of them. And aside from the small molecule therapies, there are new innovative technologies that are being trialed, including these CD34 cells that are enriched in normal mitochondria that are re-injected in kids with Pearson syndrome and Kearns-Sayre, enzyme replacement therapy for thymidine phosphorylase for Mingi, as well as allogenic stem cell transplant, and a lot of gene therapies specifically for Leber hereditary optic neuropathy. You can easily find all the ongoing clinical trials on clinicaltrial.gov. The quick search this morning showed 49 active studies, so this is a very rich environment right now and very exciting time to be working on mitochondrial disease. These are the ongoing trial that we are conducting now at Mass General and internationally. There is IW6463, a nitric oxide donor for MELAS, a phase 2 trial, nucleoside therapy for TK2 myopathy, both pediatric and adult onset, EPI743, which is now called PTC743 for pediatric mitochondrial epilepsy, as well as REN001 and ASP0367, both PGC1 alpha modulator and both in adult mitochondrial myopathy. So if you have patients and you're interested in sending them over, you can look these up on clinicaltrial.gov. There are at least 3 more trials that will be starting in the next by the end of this year and beginning of next year. So where do we go from here? We still have a lot to learn about mitochondrial disease. We need to better understand the disease complexity, better come up with diagnostic monitoring tools, and find that cure. And that can only be achieved with international collaboration, including advocacy group. There are so many of them, and they are all working together under the umbrella of the International Mito Patient. We have scientific society, the Mitochondrial Research Society, the Mitochondrial Medicine Society, which I'm the president for. Our mission is to educate providers, and we publish all our consensus guidelines for clinical care, diagnosis, prevention, freely available or on our website. And I would urge everyone to go on our website and become a member so that you can have access to all the new information and emails. We have clinical research and scientific research consortia, the North American Mitochondrial Disease Consortium that is NIH funded and is physician-led, curated registry and biorepository for mitochondrial disease, as well as our counterpart, Genomit, in Europe and Japan. And then in the US in 2018, we have established the Mitochondrial Care Network with mitochondrial medicine expert clinical sites, where we are trying to centralize all our patients, where we see them and we provide the same care and the same management. And finally, this is one of the efforts that I have been leading in the past year, which is to create a new clinical trial consortium called Treat Mito for Translational Research, Advancing Therapy in Mitochondrial Disease Consortium, which is going to allow for a centralized ecosystem of collaboration, resources, and data associated with multiple mitochondrial disease initiatives to accelerate clinical trials. I'm just going to go quickly through this. We have collaborated with the FDA in their rare disease new unit, and several advocacy groups in the US have brought patients to talk to the FDA so that we can educate them, doing workshop at the complexities of mitochondrial disease to try to have them become a partner to accelerate the cure and enhance the pipeline to clinical trial conduct for mitochondrial disease. And with that, I will conclude by saying that mitochondrial diseases remain a very heterogeneous and complex group of disorders. If you put them together, they are not as rare, and mitochondrial dysfunction is now at the heart of many common disorders, which is bringing more interest in mitochondrial medicine, and there still remains a tremendous unmet need. But with all of that, there's a lot of hope due to all these international collaboration for trials, foundation, consortia, and research. So hopefully in our lifetime, we will find that cure. And with that, I will end, and thank you.